Testing. Let me turn this one on. Okay, we're going to go ahead and get started, guys. So this is Dr. Steve Roy, and I'm going to do my best to introduce him. It's kind of a monumental task here. So the talk he's going to give today is related to altitude medicine and physiology. The background to this is that our last year chief resident, myself, went and did the diploma in mountain medicine in Canada, and that's where we met Steve. And just from our personal experience, we'd both done a lot of wilderness medicine over the years and seen a lot of talks, but Steve definitely had a pretty amazing approach to education within the wilderness medicine realm, and he was passing through town, and so we did everything we could to get him here today to give a talk. So he is trained as a critical care physician at the University of Calgary, but before that he did a master's in neuroscience and also computer science. And he's done extensive training in wilderness and expedition medicine. So he is the program director for the only month-long resident physician elective in wilderness medicine that's held in McGill University, also in Canada. He's the founding member of the Canadian Association for Wilderness Medicine, and he's involved in a lot of research and international committees. So like the International Commission on Alpine Rescue, the UIAA Medical Committee, Aerospace Medical Committee, Education and Training Committee, the WMS for a couple committees, the Canadian Association of Wilderness Medicine Governments Committee, and I'll just stop there. So the two cool things I did learn about him just recently is, number one, he did EMT training in Fresno back in the day, and he was telling me a story about how he was in the trauma bay watching a trauma surgeon yell at a resident about doing a FAST exam, and I was like, wait a minute, that still happens. So so he knows more about our situation than he might let on. And then the other cool thing that I just learned is he was the winner for the International Design Excellence Award. So he, working in the ICU a lot, he created a device that allows individual pressure control for each patient when sharing a single ventilator. So he's like the first guy to do that during COVID, which I had no idea. So obviously Steve has a lot of expertise, but today he's going to talk to us a little bit about altitude medicine. And so we're going to use this microphone, and at the end we'll have a brief opportunity for questions, and we'll pass around a microphone as well, so you guys we can all hear your questions for the recorded talk. Okay, I'll turn it over to Steve.
Awesome. Thank you so much for the very kind introduction. It's really nice to be back in Fresno. So a big thanks to Miles and Dr. Champagne and your other faculty for inviting me to speak with you. So I'm an intensivist and high altitude medicine consultant in Calgary, Alberta, Canada. And there's already a lot of expertise in your department on high altitude medicine. So, you have multiple faculty trained in mountain medicine, Dr. Spano, Dr. Ernst, to name a few, Scotty and Miles. So I'm not going to, my goal isn't to repeat things that you may have already been exposed to. Rather, I'm going to talk about how I think about altitude illness. So last night we were having conversation with Dr. Flasgraf and Dr. Ernst about how in medical education we often teach what to think rather than how we think. And I don't think we talk enough about how we think. So my goal today is to try to do my part to to move the ladder forward. So we'll do that. This is my disclosure slides. I have shares in 2 companies that I'm a majority shareholder of that don't relate to this talk. I receive funding from these people and honoraria from these other folks. Oh no, lost one of the projectors. Yeah, well, we're working over here, I guess. So see if you can get that turned back on. So the objectives for today, I will put them in this objectives, but my overarching objective again is to talk about how I think rather than this material per se. But we're going to talk about the key pathophysiology of important altitude illnesses. I want you to be able to identify AMS, high altitude cerebral edema, high altitude pulmonary edema at the end. And we're going to describe the key treatments for altitude illnesses. But we're going to recreate how to get to those treatments rather than just memorizing. So you've probably already memorized some of those things. So when I learn about a disease, I like to build a mental model, a simple mental model that allows me to understand some of the key features of the disease. And ideally, that model is accurate. But what matters is actually not whether the model is accurate at all. What matters is whether the predictions that are made based on the model are useful. So the good example of that is the way that we interpret blood gases. So you've learned that you read the blood gas and you look at the bicarb and you look at the CO2. And part of the premise of that is that the bicarb is somehow an independent variable. And that's a lie that we've been told, right? It's a lie, but it's a useful lie because you can do the way more complex but more accurate way of interpreting a blood gas and get to the same result like 10 minutes later. And for what, right? So what's useful is so I'm going to give you some an example of how I think about altitude illness, but it's not about how accurate the thinking is. Like some of the things I might describe may not be perfectly accurate, but they get you to the right conclusion, so it's useful. So that's sort of just to preface that the accuracy is not what I want you to take away from this. It's the process of and the utility of the mental model that I want you to take away from it. So yeah, let's with that in mind, I'm going to talk about the management of the 1 most common and the 2 life-threatening altitude illnesses. And I think that their management can be remembered and essentially derived from really a few physiological principles that you may already know about. I think these physiologic principles lead us to make useful conclusions about treatment of these illnesses. And to set expectations, I'm going to mostly talk about my mental model today. I'm going to stick to conveying that. I'm not going to talk about epidemiology, which is important to understand if you're working in the mountain medicine space. I'm not going to talk about guidelines, even though the treatments I'll discuss are the guideline recommendations. My goal is really to strictly focus on the internal model that I use. And so by the end of the talk, you should be able to understand how organs in the chest, in the abdomen, in the head, and the neck actually determine an individual's ability to adapt to changes in altitude. And by extension, you should understand how to treat those illnesses and the problems that result at a high altitude. Okay, so I've spent a lot of time sort of setting the expectation of how we're going to proceed. Here's a quick bird's eye view. We're going to discuss as concisely as possible for me. And then we're going to mix the principles with the discussion about common altitude illnesses. So we're going to start with just discussion about altitude. We need to define altitude in a useful way. And the useful way is to describe what altitude is, descriptively, and that is hypobaric hypoxia, meaning low pressure, low oxygen, right? Like when people say, you go to the sources in the ICU, we often, the pimping question is about the types of hypoxia. And one of them is often low FiO2, right? That's wrong. Well, it's not wrong. It's technically a kind of hypoxia, but that's not one that most people actually experience. Like that means that your asphyxiating. That's the only condition where you have low FiO2, right? The normal thing that happens at high altitude is that the FiO2 is normal. It's 20.95% oxygen. It's just a low atmospheric pressure, so the partial pressure of oxygen that results is lower. So let's talk about what hypobaric hypoxia is. If I just like went through that way too fast, we'll revisit it. But this is, if you only remember one thing from the talk, this is what you remember, right? All altitude illnesses arise from the same problem, and it is hypobaric hypoxia. If it didn't result from hypobaric hypoxia, it's not an altitude illness. It's a mountain, it might be a mountain related problem, but it's not an altitude related problem. That makes sense? Like if you go to Mexico City or you go to another high altitude place that's not on a mountain, you can get an altitude illness, right? But you're not going to get a mountain related problem, right? Like you're not going to get snow blindness from being in the city, hopefully. It's technically possible, photokeratitis, but so we're going to talk about start with this. So this is like flashbacks for everyone about med school. Like, oh shit, like why is this on the screen? I thought, you know. So let's just simplify this. This is super unwieldy, and I think the most important part of this formula can be simplified. So let's just take. I'm going to take the liberty of changing this. I feel like I'm not supposed to do that, but we're going to do it anyway. So we're specifically going to take this thing here. Offers us a method of trying to calculate the alveolar pressure of CO2 because that wasn't measurable, and alveolar CO2 is just essentially like what this Van Ron and Otis person were trying to calculate. Let's just swap out this whole thing and call it PaCO2, okay? Which we just can't measure, but that doesn't matter. This is for thinking, not measuring, okay? So now the old alveolar gas equation, like this is a little bit better. This is wieldy, right? So you have the oxygen fraction in the alveolus, and it's proportional to the fraction of inspired oxygen multiplied by atmospheric pressure minus the pressure of water vapor, which is constant, and then minus CO2. That's it. That's all that the formula says. It talks about 3 gases in the lung. Doesn't even talk about the nitrogen part, right? That's basically the remainder. So this actually gives us, we'll call it alveolar gas equation version 2.0. This is actually really useful because now we can understand that basically what the alveolar gas equation tells us is that alveolar oxygen depends mostly on FiO2 and atmospheric pressure, with this like tiny little bit that's dependent on the amount of CO2. So if this is what, if this idea actually tells us all we need to know about most altitude illnesses, really. I'm just going to describe this in a little bit more detail so that we're all like on the same page about Boyle's law. And maybe that's not, you know, a little bit too physics based for this, but I'm just going to quickly talk about Boyle's law. And then if you understand what this means, then we will be on the same page and be able to move faster through the rest. So basically atmospheric pressure, 760 millimeters of mercury, and a portion of that air that's oxygen is 21%. And so that gives us a partial pressure of oxygen of 160, okay? And that's at sea level. If you go up, you see what happened here. The molecules get farther apart, right? This is me almost 20 years ago, I guess now, at about 7,000 meters above sea level, or 22,800 feet in imperial units. I'm doing my best here, speaking American. So at that atmospheric pressure, we're talking about 308 millimeters of mercury. The PO2 is 65 millimeters of mercury, the partial pressure of oxygen. You can see that the oxygen has dropped, but not because the fraction has changed. The fraction is constant, right? So hopefully none of the ICU attendings here that ever hear again that the FiO2 has dropped, right, as the cause of oxygen. It's that the partial pressure of oxygen has dropped, which encompasses both types of atmospheric change, right? If you have a low FiO2 or if you have a low pressure and a fixed FiO2. So if about 40% at this altitude at 7,000 meters, we have about 40% of the oxygen pressure that we're used to. That's low, right? So we can fix this based on like what our description of what's happened, we can fix this two ways, right? We can fix this by increasing the pressure and pushing these molecules back together. That fixes everything, right? Like this is either descent or a hyperbaric chamber. It results in the same thing, right? The oxygen molecules closer together, so more of them get into the alveolus. Or we can take the one that has the exact same pressure and we can just supplement it and increase the FiO2, right? Both of these have the exact same effect on well, not exact, but they can't, you can have they don't have the proportional change is slightly different, but effectively these two methods can both be used in exactly the same way. Like if I treat someone with supplemental oxygen and restore that oxygen pressure, it has no difference if I do it by supplemental oxygen or by hyperbaric chamber. It's like I hear that all the time. People are like, well, we gave oxygen and then we're like, but we don't have a hyperbaric chamber. It's like, that's perfect, right? You only need to do one of those two things. If at a certain point, if you're breathing 100% FiO2 at any altitude, it's normal, right? The problem is no longer the hypobaric, low pressure, hypoxia, low oxygen. So just to prove this a little bit, again, there is a slight difference in the lung, right? Because in the lung, we have we have water vapor and CO2 that screws with this a little bit. But the main point is that if I change the altitude, functional altitude or actual altitude, I can get us back to 130 millimeters of mercury. And here, I've doubled the oxygen FiO2 instead of changing the altitude. I got to the same result. So both ways fix the problem of hypobaric hypoxia. So now that we've defined hypobaric hypoxia means, we should quickly define what high altitude means, just for thoroughness. High altitude is usually defined as starting around 1,500 meters sea level, which is where the physiologic stress of hypobaric hypoxia starts. It's not usually, it's very uncommon to get an altitude illness that's of any severity at that altitude. It's actually possible, and there are people with pre-existing medical conditions that do, right, who are more susceptible to shunts and things that will drop their oxygen farther than others. But it's uncommon, but this is where we describe the start of high altitude. It's more common to get altitude illnesses above the 2,000 meter, above the 3,000 meter mark at the very high altitude, as I've shown here. And acute mountain sickness in particular becomes common at very high altitude. And it's at the extreme altitudes that we start to really get the high rate of the life-threatening altitude illnesses. But really, I would say anywhere above the 3,500 meter mark, your rate of altitude illness, of the severe altitude illnesses, is higher. And this is, we use this in the chapter on mountain emergency medicine. We use this altitude precisely because this is the point in the Andes or the Himalayas where barometric falls to half the pressure of sea level. So that's kind of why it's defined that way. So enough about that. Hopefully the alveolar gas equation stuff was not, didn't set you off, trigger any PTSD. And we can move forward with physiology, which is really the exciting part. So this next piece is going to be critical to the understanding of altitude illness. And I'm going to explain it in 3 slides because it's also conveniently very simple. So ventilatory control. So we were told in medical school something, maybe we were told different things, but ventilatory control is tightly regulated by 2 main mechanisms. It's not just by pH, right? So central chemoreceptors in the medulla, specifically in the ventrolateral medulla, are extremely sensitive to pH. They help determine our respiratory rate to keep that pH constant. But we also have peripheral receptors in the carotid bodies that are sensitive to low oxygen, low PO2. And they are also a stimulus to breathe. In people who have chronic COPD, the reason why we are sometimes hesitant to give high fractions of oxygen is actually that they've become desensitized to the pH. The problem isn't that this is now new. The problem is that this is now gone, right? They have high levels of bicarbonate bicarbonate because they have metabolic compensation for like just a chronic respiratory acidosis. So what's changed is this in them, but this was always there in the background. And when this goes away, this becomes more important. So this is, for all intents and purposes, the first method of ventilatory control is the more potent. And so, you know, it's all we really focus on, and that's appropriate most of the time. But when we go to significantly hypoxic conditions, the hypoxic ventilatory response is activated, where the body says, the amount of oxygen here is too low, I should breathe faster. The problem is, HVR is activated, but under even slight hyperventilation, the decrease in PCO2, respiratory alkalosis, decreases arterial and subsequently CSF pH. So as soon as I have those changes in pH, because the brain is way more sensitive to pH than it is to the oxygen, the hypoxia, then the brain says, nope, we should not breathe any faster than this. So the way that I think about this is in the setting of acute exposure to hypobaric hypoxia, the initial hypoxic ventilatory response is submaximal. It's inadequate. It's not as good as it could be. This ends up being really important. After ascent to high altitude, our hypoxic ventilatory response is limited by central ventilatory control, i.e. pH. If you think about it this way, now you understand, we're able to talk about how we actually compensate to altitude. How do we acclimatize? So this would be a rather unexciting story. Enter the hero of the story, the kidney. And I know what you're thinking. You're thinking the kidney is rarely the hero of the story. I think that's fair criticism. I'm also not biased against the kidneys, so I'm going to ask you not to accuse me of being nephrologist just yet. And that's probably the best dad joke you'll hear today. So let's we'll talk about renal responses to altitude. Little asterisk here that primarily the response is to respiratory alkalosis and a bit of hypoxia, not to the altitude per se. Does that make sense? Like what I'm saying is, when you go to a hypoxic environment, you want to breathe faster. You start to breathe faster, brain's like, yeah, not that much more. And then that's what's limiting you. Your kidneys are responding probably more to that than to the altitude. If that makes any sense. But we'll call it renal response to altitude because that's how everyone else talks about it. So under significantly hypoxic conditions, we get hypoxic ventilatory response. We get this metabolic this respiratory alkalosis. And this increases the renal excretion of bicarbonate. We call this bicarbonate diuresis. And this decreases the drive to breathe. This decrease, or the pH going up decreases the drive to breathe. But as we pee out bicarbonate and we get a compensatory metabolic acidosis, this brings the pH back down, allowing our hypoxic ventilatory response to be more maximal. So it's literally the kidneys that are why we acclimatize to altitude. Like this whole idea of like red blood cell, production, like that's for next month, right? But presuming that you're not climbing, some mountains take a month. Most of you, when you're going to the mountains, are not going for a month. You're going for a week, 2 weeks, maybe 2.5 weeks, right? So in that order, what's going to happen is that you're going to have acclimatization through bicarbonate diuresis. So after 24 to 48 hours after a relative ascent to high altitude, you get a reasonable hypoxic ventilatory response at most terrestrial altitudes. You'll feel pretty good. And this is because of the kidney. So if you were rooting for the kidneys, you're in luck. This brings us to our third takeaway. And that's that initial acclimatization depends primarily on renal bicarbonate diuresis, allowing a maximal hypoxic ventilatory response. Okay. So far, we've talked about 3 physiologic principles. I've shared 3 take-home messages, 2 dad jokes about the kidney. We're going to talk about 1 physiologic principle left, which we'll address before the end of the section, but I want to start getting into the acute altitude illnesses. So let's start that. So acute mountain sickness. So acute mountain sickness is a syndrome that occurs in the setting of acute ascent or further gain in high altitude. And it's really like a hangover. That's how we describe it, right? It's about as dangerous as a hangover. And it feels in many ways like a hangover, right? We diagnose AMS clinically, and it is essentially a syndrome that involves a headache, by definition, high altitude headache, and other symptoms like gastrointestinal upset, fatigue, generalized weakness, dizziness, lightheadedness, and some people think perhaps asleep. This is a matter of debate that I'm not going to, get into right now. But I just want to bring a quick note related to acute mountain sickness. So this is the 2018 Lake Louise mountain sickness score, and this instrument is often used. You'll hear people have people in the field calculate this score, and it's not wrong. It is a little bit wrong. It's not completely wrong, right? But the Lake Louise score in this article, or in this guideline, there's like 100 names in there. I'm somewhere in the middle there. That this statement is found. This Lake Louise AMS score for use by investigators studying AMS. It is not intended for use by clinicians, professional outdoor guides, and lay persons to diagnose or manage AMS. So I'm not going to go through the whole Lake Louise score. You'll hear it in other talks or in other training. And I just want you to remember, I'm going to plant this seed. That's not what the Lake Louise score is for. Okay. You can diagnose acute mountain sickness in someone who has a Lake Louise score that is insufficient to meet the criteria, but they have clinical high altitude illness. And you can have people who meet the criteria. I've had people call me, from high altitude places and be like, yeah, I'm like headache, like gastrointestinal, like I just feel nauseous all the time. And I get the story, and they've been at the same altitude for like 4 days. Like, are you sure that this isn't just a gastrointestinal illness? And it's like, no, I don't think so. Called me later. I'm like, just wait on the acetazolamide. Later that day, called me back. Yeah, definitely GI, right? So you can get a headache if you're starting to be dehydrated. You can get like lots of these symptoms of feeling crappy are not specific. So having a positive test or a negative test of Lake Louise isn't the point. Acute mountain sickness is a clinical diagnosis. So that's the only rant about acute mountain sickness that I'll incorporate today. But this is the way that I think about acute mountain sickness when I internalize it. Acute mountain sickness occurs in patients or in people who are insufficiently acclimatized. That's it. So if you have a hangover symptom at high altitude, it means, hey, you're not acclimatized, stop going up, right? Like, why continue? Like, you're not ready. I'm not ready. The kidneys are lagging behind as usual. Like, give them a chance to catch up so we can do this thing, right? That's how you have to think about it. So I see acute mountain sickness not in itself as a major problem. I see it as a sign that the person is not acclimatized, which is what matters to me, right? Like, I'm there to do something at altitude, not just to feel good hanging out at altitude. Oh, that's fun too. Often it's for a mission, right? And so what matters is like, am I ready? Like, think of it as in sports medicine thinking, right? Like, should we continue on this injury? Like, is it ready are we ready? No, we're not ready, right? The concussion, more similar, perhaps, like brain problem. So acute mountain sickness. I'm not going to talk about pathophysiology of AMS. Like, this is not the point. Just thinking of AMS as a result of insufficient acclimatization. That's to me, that's where the usefulness of this physiologic approach is. So it's a hangover, it's a nuisance, it's not life-threatening, it's a sign. So as I said before, all high altitude illnesses are caused by hypobaric hypoxia. So here we have uncomfortable hypobaric hypoxia. So how can I treat uncomfortable hypobaric hypoxia? I fix the hypobaric hypoxia, or I let the body catch up. So you let the kidneys catch up, you spend 24 to 48 hours to let them compensate. Or you can whip them into shape with some acetazolamide, right? You just pull out the Diamox whip, beat those kidneys into submission. You make them pee out more bicarbonate faster. Instead of the 20, 40, 48 hours, it's 18, you know, it's kind of like 12 to 16, 18 hours. And now you've just achieved the same thing, but faster. You'll hear people say that you get a compensatory respiratory alkalosis, and that's not the point. It is true that you have that, but in this model, the problem here was submaximal hypoxic ventilatory response. It's true that you might make them breathe faster above the hypoxic ventilatory response with the acetazolamide, but I wouldn't think of that as the real reason it's useful. In my mind, the real reason it's useful is to do what you are going to do already, which is to get that bicarbonate out so that I can breathe a bit faster. To me, that's literally how I think about acclimatization. That's it, not really much more. So besides improving the hypoxic ventilatory response, we stop ascent, we let ourselves catch up, we treat headaches symptomatically, we can use acetazolamide. If oxygen is there, I can do low flow. I fix the hypobaric hypoxia and the problem caused by hypobaric hypoxia goes away. I can descend, and ascent is contraindicated. Yeah. Good question. No, it's not detrimental, but often people are using oxygen for either because they're like more than just acute mountain sickness sick, right? So shouldn't continue. They shouldn't like use that, you know, to like get them. It's like just giving. Yeah. Yeah, exactly. Like put a Band-Aid on this like giant lac and just like, yeah, just tough it out, right? Yeah, pain is weakness leaving the body. Just keep going. So yeah, so the problem is that people use oxygen and in I think the wrong way. Like if you're using it at very, very high altitudes, like death zone level, that's for safety, right? It's because more people die when they can't coordinate walking. We could probably, yeah, people have different feelings about this. I'm okay with it, right? When I've met other people who have, you know, went to climb Aconcagua in South America, it's the tallest mountain in the Andes, and that was the one that the photo was taken from, and who have failed 3 times, and then they're like trying to arrange for these like $1,000 bottles of oxygen to come from Russia and carbon fiber tanks, and it's like, just go slower. Like that's a better plan. Right? Like, so if I lots of times the oxygen is coming in and you're like, it has to be thought carefully, right? Like, why am I using oxygen and not descent or time, right? Is it because I'm impatient? Like, what is the reason? Acetazolamide is going to be better because that actually is helping me acclimatize, as opposed to the oxygen, which is just relieving temporarily the environmental stress, only to have it come back. I'm not sure if that answers your question.
No, that's exactly.
Yeah, perfect. We can also prevent altitude illness. Now, really, the solution to prevention is going slow. There are a couple treatments that are recommended. Gradual ascent is the one, right? Like you go look at people climbing Kilimanjaro and you're like, okay, why do these trips all say like 5 days, 6 days? If you calculate WMS guidelines, UAA guidelines of how long it should take 13 days to climb Kili. No one is doing that. And that's why everyone is getting acute mountain sickness and high altitude pulmonary edema, right? It's because they're not wanting to go slow. So go slow, enjoy your surroundings. You can take acetazolamide. I was told once that by a nephrologist that acetazolamide is a weak diuretic, which led me to believe that the nephrologist had never taken acetazolamide. You take it the day before you travel so that you're not bicarbonate diuresing in the aircraft. You want to do that at home, ideally. There's also guidelines that suggest using dexamethasone for prevention. I think that's a terrible idea for 2 reasons. One is that people just end up taking it every day and they get something, adrenal insufficiency is kind of a worse problem than hangover. And the second thing is that then now you have no rescue when like the person feels fantastic, goes way faster than their body is acclimatized to. So I'm going to omit dexamethasone from my prevention suggestions there in conflict with maybe other guidelines. So high altitude cerebral edema is thought to be on a spectrum with acute mountain sickness, mild being AMS, severe being HACE. And I'm really not sure that this is accurate, but it's at least useful. So we're going to go with that. Unlike the hangover symptoms of AMS, HACE is a patient appears drunk still, right? Like this is how we're differentiating the two. And the exact pathophysiology of blood-brain barrier breakdown is debated, and there are competing theories. There's like this tight brain hypothesis, the venous limitation theory, lots of these like things we're not going to talk about. The point is it's a life-threatening neurologic condition triggered by ascent to altitude, and it's characterized by the accumulation of cerebral fluid in the brain, extracellular fluid, and it results from a breakdown of the blood-brain barrier. And it's distinguished by neurological alterations, ataxia, altered consciousness, anything that looks like a stroke could be acute high-altitude cerebral edema. So I'm going to focus here on the breakdown of the blood-brain barrier. So if we to take this physiologic approach, if we say HACE is caused by a breakdown of the blood-brain barrier, then caused by a change in altitude, then the treatment is to treat life-threatening blood-brain barrier caused by hypobaric hypoxia. So you should be able to tell me how we're going to treat this. We treat it with descent. We eliminate hypobaric hypoxia. We treat with dexamethasone, i.e. treating life-threatening blood-brain barrier breakdown, swelling. We treat with oxygen, decreasing hypobaric hypoxia. We treat with hyperbaric therapy, portable hyperbaric chamber, not the kind that's used for portable hyperbarics for dive problems. Those are much heavier and more expensive. These are just the small containers that we can pump up, bring someone down just to sea level. We don't need to bring them down to 3 atmospheres. We're just doing even approaching sea level. So hyperbaric therapy, so we fix the hypobaric hypoxia. We can even use a PEEP valve, like if we're bag valve masking someone who's like really sick, we are increasing intrathoracic pressure. We're increasing the pulmonary pressure of oxygen. So this is the last thing I want to talk about. It's a high-altitude pulmonary edema. So let's first talk about the last physiologic principle that we need to understand, HAPE and its treatments. So hypoxic pulmonary vasoconstriction is a process where blood flow is restricted to lung units that are poorly oxygenated. And this contributes to ventilation perfusion matching and prevents significant hypoxemia in the setting of a regional lung problem. So just to sort of explain this more, so you have blood coming from the heart, from the right side of the heart. It's going through these blood vessels, past the alveoli, getting rid of CO2, getting oxygen, and then going back to the left heart. And sometimes we have an alveolus full of pus. And if we were just to leave this alone, we would get this blood that would have done no gas exchange, and so would have a lot of CO2 and lack of oxygen. And this one that's fine, and then it mixes, and it ends up being less oxygen overall, right? So instead, what our body does is it says, yeah, this pus, let's not spend a lot of effort sending blood to a lung unit that's useless right now. Let's constrict that, and by virtue of a fixed output, more flow is going to go down to this lung unit that's working, and we're going to maintain relative oxygen saturation. So this is why you guys see all the time patients who come in with a walking pneumonia. They have this lobar pneumonia, and they're like fine, particularly kids, right? They're like have this full. They feel like shit, right? They're febrile. They're infected, but their oxygenation is often good, right? Like you've seen these people, right? Their oxygenation is 98%, and they've got this like whiteout of an entire lung segment. Our body is built to not die from that, right? Like that's why we have this hypoxic pulmonary vasoconstriction. But when you go to high altitude, you don't have a regional lung problem. What you have is hypoxia in all of the lung units, right? So when you get diffuse hypoxic pulmonary vasoconstriction everywhere, there are no young lung units to send the blood where the oxygenation is great, right? Because they're all hypoxic. So you just get, instead of redirecting the blood now, you just get pulmonary hypertension, right? Like 100% of people who go to high altitude get pulmonary hypertension. It's just how much pulmonary hypertension and how much they can tolerate. That's the only question. The question is not, is the pulmonary pressure going to go up when you go to high altitude? The question is, how much is it going to go up? And how much do I allow myself to adapt before stressing my system more? So, so in this case, when it's severe, you get this bilateral basilar predominant pattern of puffy, patchy edema that we call non-cardiogenic pulmonary edema or high altitude pulmonary edema when it's caused by high altitude. So this is one of the last takeaways. HAPE is caused primarily by diffuse hypoxic pulmonary vasoconstriction. I don't think of HAPE as anything except this. It is probably more complicated, as most things in the body are. Every time you think like this is really simple, it's like you like learn the next level, you're like, oh man, could not have been more wrong. But the reality is that this is close enough to get us to the right answer. Literally all of the treatments that we have for high altitude pulmonary edema, like fit this explanation perfectly, right? So if we think about it this way, it's very useful. So at high altitudes, we have this hypoxic pulmonary vasoconstriction that's no longer adaptive because the hypoxia is diffuse, not regional. For this reason, unacclimatized people will have this degree of pulmonary hypertension. And when it's severe, it becomes a positive feedback loop, right? It's severe, so you have more hypoxemia in the blood, right? Blood hypoxia, hypoxemia. So then the hypoxic vasoconstriction is worse. So pulmonary pressure goes higher and it's a positive feedback loop. That's not going to fix itself. That's going to get the person real sick. And statistically, the people who get this are young people, not the older people who are working hard at altitude, whose right heart is pumping a lot of blood against a high resistance. Like racehorses at the end of the racehorse, when they have like diffuse pulmonary edema, because this like massive heart's been slamming like liters of blood through the lung at high pressure. That's what is happening at high altitude, except that it's the environment causing it, not just the activity. So in terms of high altitude pulmonary edema, the diagnosis is it's a potentially life-threatening respiratory condition triggered by recent ascent or reascent to altitude. It's characterized by non-cardiogenic accumulation of extracellular fluid. I would say that people who have heart failure can still get acute mountain sickness or high altitude pulmonary edema, right? There's probably more at risk of high altitude pulmonary edema, but no one's going to call it high altitude pulmonary edema. They're going to call it exacerbation of CHF or something, right? So, because technically the definition here is non-cardiogenic, but they're not mutually exclusive per se. Impaired ventilation due to the presence of fluid causes dyspnea on exertion, increased recovery time, progressing to resting tachypnea and dyspnea. What you did not see on this list that you will see other places is what? Hemoptysis. If you are seeing hemoptysis, you missed the boat. Okay, the boat sailed and you didn't notice. It was gone. Okay, the boat is you should be noticing when the patient has dyspnea on exertion or on rest, right? This patient is resting and they're dyspneic. You're not like, hey, let's keep going until you cough up blood. Okay, if you see hemoptysis, you missed it. Okay, the symptoms are trouble breathing because of fluid in the lung. That's the problem. We won't talk about the implications on ultrasound because I'll just mention a lot of people who do not have pulmonary edema have B-lines. So there's a lot of B-lines at altitude, and it doesn't mean high altitude pulmonary edema. So this is another place where clinical diagnosis, right? So how do we treat high altitude pulmonary edema? We treat excessive hypoxic pulmonary vasoconstriction caused by hypobaric hypoxia. So the definitive treatment is descent. We can provide rest. Rest decreases heart rate. By definition, if you decrease heart rate and you keep stroke volume constant, you're decreasing blood pressure, right? If the hypoxic pulmonary vasoconstriction, like if you're decreasing heart rate and cardiac output is a function of heart rate and stroke volume. So stroke volume is the same. Heart rate goes down. You've decreased pressure. You're decreasing the amount of pressure in the lungs. So we rest these people in addition to giving them oxygen. So we fix both parts of the pressure and the resistance. We can give them hyperbaric therapy, PEEP valve, BiPAP, CPAP, whatever. We can also give them nifedipine, which is a pulmonary vasodilator. And that is very effective. Like people who get high altitude pulmonary edema often get it again. Like there's a genetic predisposition. It's like 20 times in some cases the rate of recurrent high altitude pulmonary edema. And when you give them nifedipine, they don't get it. They don't climatize quite as well either. If you're doing exercise at altitude and you're impairing hypoxic pulmonary vasoconstriction, like there are losses there, but they don't die of high altitude pulmonary edema. So that's bonus. You can also use PDE inhibitors, so sildenafil, tadalafil. Those are also effective because they're pulmonary vasodilators, and the problem is hypoxic pulmonary vasoconstriction. So to prevent HAPE, we prevent excessive HPVC. So gradual ascent, acetazolamide, nifedipine, and potentially PDE inhibitors. I don't recommend HAPE prevention prophylaxis for people who have not had HAPE before, because all you're doing is screwing with physiology for no good reason, right? That gets you into trouble more. That you have someone now who has lightheadedness all the time and like they're trying to be on a mountain with like sharp things in their hands. Like, nah, I'm not sure that's a good idea. So instead, just we prevent high altitude pulmonary edema in people who are at risk. So that might have been a little fast. Hopefully it was useful. Just to review what we talked about, a few physiologic responses to altitude. At this point, you should understand how organs in the chest, the lung, the abdomen, which one in the abdomen? The kidneys, the head, the brain, the neck, carotid sinus, determine your ability to adapt to high altitude, okay? So the key concepts were that acute mountain sickness occurs in patients or in individuals who are insufficiently acclimatized, like that's what it means. HACE is caused by a breakdown of the blood-brain barrier. HAPE is caused by excessive hypoxic pulmonary vasoconstriction. We treat by reversing or improving this problem. After ascent to high altitude, hypoxic ventilatory response is often initially limited by central ventilatory control, and that initial acclimatization depends on renal bicarbonate diuresis to allow maximal hypoxic ventilatory response. And if you remember nothing else, altitude illnesses all rise from the same general cause, hypobaric hypoxia. And so if we treat hypobaric hypoxia, we fix the problem. These are references. Thank you for your attention. Thank you to Dr. McDonough, Dr. Ernst, Dr. Felsgraf for your gracious hospitality, and I'd be happy to take any questions.
Thanks so much for coming. Is this on?
I'm not sure it's on. Press the power button, see if it's. They have to do over here. Oh, wireless mic one. Here, try again.
Hello?
On? No?
Also.
Okay.
Oh, can you hear me now? Yeah. All right, awesome. Thanks so much for coming, Dr. Roy. I was wondering, I know there's a lot of like individual variability in who gets like HACE, AMS, HAPE. Are you aware of like any research markers or like individual kind of demographic things that would affect susceptibility?
Yeah, that's a good question. I'm going to give you my less filtered answer. So I think high altitude pulmonary edema, there is research because we know it's clear there's a genetic component. Just the rates are so much higher in people who have had it. AMS, I'm less convinced. There probably is, like there's individual variability. But there's also things that are not genetic per se, right? Like people who have renal dysfunction, I wouldn't expect them to compensate as well to an acute change. I think of myself, I work in intensive care, right? But I think of myself as a homeostasis expert, right? And imposing homeostasis on people who have failure of homeostasis. That's sort of how I think of it. And so that's in that light. So when I was in medical school, probably the thing that was most memorable was this Jerry rotation, which I thought was going to be terrible. It was okay, but the geriatrician, this Dr. Gold, she said think of frailty, which is this like nebulous term that means nothing. Think of it as homeostenosis. And I was like, you win. You are the best geriatrician. Like you've nailed it. You've described in descriptive terms. You've given me a way of thinking it that I can use. So I think of problems like people who have frailty as homeostenosis. So people who have an inability to be stressed, their range that they can homeostase in is really narrow. So you like it's like balance, right? Like people with good balance, you can give them a good push, they don't fall over. People who have like crappy balance, you barely touch them and they're like on the floor, right? So this is homeostenosis. So people who have varying degrees of diseases that affect their respiratory system, their cardiovascular system, like of course those things are going to interact with altitude illness. But I don't think that there's a specific genetic disposition. If there's anything, it's in the brain, right? It's decision making, right? Like people who go too fast and make dumb decisions one day, statistically, they're going to make a dumb decision on another day, right? So when people are like, yeah, I got altitude, I take AMS, I take acetazolamide now because I got AMS on Kilimanjaro. It's like, yeah, you were there for 4 days. Why do you think you got it? Because you ran up a giant mountain and you didn't let your trailing kidneys, they're like being dragged on this rocky surface all the way up the hill, right? Like that the problem is judgment there. And so I think that's probably, this is I told you it'd be my unfiltered. I think that the problem with recurrent AMS is often related to decision making and disease burden, as opposed to a genetic problem per se. In contrast, I think of hypoxic pulmonary vasoconstriction and things like intracardiac or intrapulmonary shunts as being very clearly the cause of that's going to be more genetic. There is very good evidence that a patent foramen ovale will increase your rate of acute mountain sickness. That's the one thing that I would say, and it's extremely common, right? It's common to have a probe patent foramen ovale on autopsy. That doesn't mean you have a foramen ovale that's patent physiologically while you're alive. It just means when you're dead, someone was able to show that there was. But when there's blood pushing on it, it might not be. The incidence of that is huge though, right? Like 30% of the population has a probe patent foramen ovale. Probably like 10% have some sort of shunt at some point during exercise or hypoxia or exercise in hypoxia, right? So I think probably patent foramen ovale is probably in terms of really clearly biological contributions, one of the bigger ones, in addition to judgment.
Excuse me, a couple more questions.
Thanks again for coming to talk. I had a question as this pertains to aerospace and flight medicine, especially since it's developing. Are these physiologic principles something we'd be concerned about in that acute period, or does it generally take a little bit longer for things this severe to develop?
Yeah, no, it's actually relevant, and it's part of the planning. It's part of some of the planning. So when they decide the habitats, right? Like they're deciding on the habitat, whether to breathe. So they're managing two things in space medicine. We're managing people going outside of the spacecraft where they're being decompressed, and so they get decompression illness. Get the bends in their spacesuit outside. That seems like a bad idea, right? So we're trying to avoid that, and at the same time, trying to avoid problems induced by by altitude illness essentially also, and by really subtle things. Like we don't really, we're talking about these hypobaric environments because in the spacecraft, because the atmospheric pressure on Mars is like almost really low. Like water, if you open a container of water, it instantly evaporates, right? Like the boiling can't exist at that pressure. So you bubble up if you open your suit, right? So we're trying to get you to a pressure that's similar to outside without you just like exploding, right? Not that you would explode, I'm exaggerating, but the point is that we're trying to get you to a low atmospheric pressure to go outside of the spacecraft, but trying to keep you like in a normal environment as much beforehand. So they were trying to balance this. And what they do is they put higher oxygen fraction, lower pressure, and the balance of that is really the key. The problem is that over time we've realized that hypobaric hypoxia is different than normal baric hypoxia, and so when you change oxygen fraction to cause hypoxia, it's different than when you go to high altitude, and that implies that there's a difference between hypobaric normoxia and normal baric normoxia. Are you following? Yeah. Okay. So to answer your question, this is important. It's part of the planning for the environment, the habitat. It needs to be part of the planning for other things too. And I've discussed with NASA pharmacists about like the planning around the medications, because medications, believe it or not, very poorly studied. It is true that hypobaric hypoxia changes how we metabolize drugs, changes how we absorb drugs, changes how drugs are delivered, and changes the stability of some drugs. Like that's a problem that needs to be figured out before we send everyone in like some non-1 atmosphere environment for 2 years away with no chance of helping them in the meantime, right? So there are other ways that this is relevant, not just in terms of the acute mountain sickness, or we didn't talk about chronic mountain sickness, and that's probably the bigger risk. Like people who live at high altitude for very long times, they have physiologic changes that become maladaptive, that make them sick from being at altitude, very high altitudes for so long. So there's this whole balance of things, particularly when those stresses occur simultaneous to a bunch of stresses related to low gravimetric environment.
Five more minutes.
Yeah, thank you for the great. I had a question about what the new normal would be for respiratory rate when someone is acclimatized to high altitude and they go through that bicarb diuresis and have a more maximal hypoxic respiratory drive, ventilatory drive.
That is a good question. So the way that I've described this is the way that I think about it, because it gets you to the right answers, right? But people haven't described, like haven't defined. There are actually respiratory rates and SpO2s that are normal. Like having a normal SpO2 at altitude is not normal. It's not normal at certain altitudes, anyways, right? Like you go to very high altitudes, and the first day you're there, you're hypoxemic, like not just like potentially very hypoxemic. I remember being, and the way that you initially acclimatize when you haven't had your bicarbonate diuresis is tachycardia, right? How do your patients who are hypoxic, what do? Like you have a limited oxygen saturation, to increase oxygen delivery, you deliver more, right? So when you go to high altitude, you're like, my resting heart rate at base camp on the first day of on Aconcagua, well, it wasn't the first day, long story. Anyways, at base camp, I woke up and I took my heart rate and I was like, holy crap, my heart rate's like 110, my saturation's like 70, right? And the next day, my heart rate was like, it had dropped dramatically just by peeing a bunch, right? Fix so there's all these, like, at what point in acclimatization do these, they're going to be, heart rate's going to be going up initially, then it's coming down, respiratory rate's going to slowly go up, then other things are going to take over. There's these transitions they're transitions. They're not target achieved, like stay the same. They're transitioning between different
physiologic systems that are taking over. Like you do start making more red blood cells. This idea that your spleen contracts and that you just release more red blood cells you already had, like right away. Animals that do really deep sea diving they do this. They have these massive spleens and they just like load a ton of extra blood cells right before they dive. So humans probably have some of these, so that we have all of these different mechanisms to adapt that have different timelines. And so it's hard to say like what a normal would be for if we weren't going for that person with their. So let me put it a different way. I think that what matters is sometimes not the number, right? As someone who works in an environment where it's all about getting numbers, you're like, I want to quantify that ASAP, right? Put in all sorts of sensors, but I think that there are times when qualitative actually tell us more information than the quantitative. We were talking about this last night. A number to me is useless. It doesn't tell me anything. The slope between two numbers is what tells me something. So if someone has a blood pressure of 120/80, what does that mean? Well, it depends if they are normally hypertensive or if they're normally like borderline hypertensive. It depends if like 10 minutes ago they were, 80 and I gave a bolus of fluid. Like what mattered is the slope. The number is actually not particularly useful to me without the context. So, but I do think so that someone feeling good is actually probably more valuable than and someone feeling crappy. Like that's what I would use as like, how acclimatized are you? I feel like crap, probably not very acclimatized, right? And there's to answer the question before also, or to go back to it a bit, like probably people who get high altitude pulmonary edema often have another thing, right? Like you go to the Kombu Valley, you get Kombu cough, you like inhale all of this like this dust that's dung, right? And there's all these other people who are there in close quarters that are sick, and you get a mild virus which causes hypoxic pulmonary vasoconstriction, right? Causes an inflammatory response, causes you to be a little bit more tachycardic. You have a little bit more homeostenosis than usual, right? You have a little narrow homeostatic tolerance. So often there's an association with an infection, recent infection, and high altitude pulmonary edema, right? And that makes total sense that there would be. But what would be normal heart rate or normal respiratory rate for one person after a recent illness? Like there's so many variables that it's hard to set those numbers, and people get so fixated on the numbers. Like one of my things that bothers me about hypothermia, it's like we've like just focused on these numbers, and the numbers are actually like super hard to measure reliably. Like they're terrible, right? So similarly here, if we look at the gestalt, the qualitative picture, I think you're going to get more out of that clinically. Although it's a good question, and I'm not giving you an answer. I think that the like big picture is to look at the qualitative. Like this patient looks good, they feel good, they're probably ready to go, as opposed to the person who's like, I feel terrible. Like that's and their vital signs look fine. I'm 100% going to monitor that patient.
We're about out of time. So Steve, can you just kind of close us out? We have a lot of med students in here as well as residents, and you run this resident elective that's a 4-week thing. It's not really available anywhere else.
Yeah.
Kind of what's like the one-liner or like paragraph, kind of like lack for a better word, like advertisement for it and your philosophy behind spending 4 weeks learning like wilderness medicine content?
Thank you for the opportunity for shameless self-promotion. Yeah, so the thinking is that there are a lot of opportunities to do wilderness medicine and wilderness first aid and these things. And my philosophy is that I want to train hard. Like I would rather train in an absolute terrible day so that when the actual shit hits the fan on the good day, it's like really easy, rather than train in like the fair weather day and then then you're like, oh, this wasn't like it was before. It was so nice that day, like, so we do a lot of simulation. My philosophy is that you learn things through practice, not through like observing practice of other people or talking about it as much. There is like knowledge to learn, but there's a really important component that cannot be taught other than through practice. And so we try to provide a lot of practice in difficult, complicated, increasing difficulty, increasing complexity of low resource medicine, and try to do like deep dive that can't really be done when it's broken up into really shorter stuff. So, and we only take residents in their second year or later, precisely so that we can move faster, right? Like we can cover stuff that you've already seen and go faster into deeper, more like, in my mind, more advanced topics. And in any specialty, the advanced topics are what get exciting, right? It's like really going into depth. So that's sort of how we think about it. We have several sites, over 1,000 kilometers that we travel between during. I drive a bus. I have a class 4 professional driver's license. So we start in one part of Quebec and we end in another part, a different mountain chain in Quebec. Like we span a bunch of different areas, and we teach different things in environments that are conducive to that teaching. We have a lot of guest faculty who come from around the world. This year we have Inigo Soteras from Spain, he's the Antarctic science program for Spain. He oversees all the physicians who work for them, among a lot of other work that he does in mountain medicine. We have historically, we have people who come as guest instructors for periods of time, and people who have guest lectures on a very specific topic. We bring people who are experts to talk to our discussion yesterday, experts on specific topics to talk about that topic, and experts on teaching to teach, if that makes any sense. Like those are different. Training and education are not the same thing, and that's our philosophy. Thank you.
So much, man.
Thank
Really
you.
appreciate it.
Yeah.
Awesome, man. That was
I'm sorry I went overboard.
No, let me, so we've got our program director back here. I'll just like introduce you to her real quick.
Yeah. Thanks so much.
Yeah, this is perfect. This is exactly what we were hoping for.
Sounds good. Yeah. Yeah, just like get your bed.
I get my thing to connect. I plugged it.
Is it all working? Let's see.
I plugged it in, but it's not coming up. We probably have to switch something over, but I didn't want to just start
Let's see. So
pressing buttons.
presentation. And so
Ah,
it's from
laptop.
the PC.
Oh.
Or no, from laptop, sorry. And then we want all these to be. I think it's searching right now. Okay, guys, we're gonna go ahead and get started with Corinne's presentation. Sorry, Corinne, we're starting a little bit late. Oh, I see what's going on. It's this is tricky. This gets plugged in. All right, so now it should start reading your computer.
There it goes. Ah, things are happening. Maybe. That looks promising.